his idea is an amazing idea, and I think many people are gonna, you know, are gonna be able to see this video many times, because this is gonna be there forever, right?
That's right. Thank you so much for the
idea is an amazing idea.
Thank you so much for the invitation, Ivo. Last time I checked, it was Monday, not Friday, but if it's Friday,
true. I'm sure.
Know, maybe you should get the beer.
It's because of Paco Carib.
No,
it's because of Paco Carib. But it's Monday.
Monday, nonetheless, it's worse. Everybody's hungover from the weekend, and it's late. Thanks for coming. So first of all, I'm incredibly impressed by what you have here. This is exceptional. The teaching resource, the opportunity to practice these techniques in artificial eyes, the technology that you have for simulated everything, really, because it's not just cataract surgery anymore, is absolutely fantastic. So congratulations. I'm really excited to be here. We've been trying to do this since before the pandemic. Yes, I've been locked up in an island for the last 3 years. So I'm really happy to be back home in mi querido Mexico. And so the plan for today is, with my dearest colleague and best friend here, Jose, is to talk to you guys about a few things regarding MIGS. We'll be doing a few devices, and we have this little idea about what we won't do and what we will do. So what will we be discussing? The science behind MIGS? Nope, go somewhere else. Sorry. That's been discussed. The indications for MIGS? Nope. No, sorry, go somewhere else. Patient selection? No, this is not what it's all about. Which device for which patient? No. So what on earth are we talking about today? Specifically and exclusively the surgical technique, the tips and the tricks for a successful and safe surgical implantation of each one of the devices that we will be talking about today. And we have them there on the black whiteboard over there.
I'm going to be taking notes because I'm the cataract surgeon with no experience, but guess what? I want to learn. I'm 40, but I want to learn. Okay, and I think the best way, the best place to learn a new technique is in a simulated environment.
Exactly. So of course you need to understand that these are not real eyes, these are not real patients. Some of the specific nuances of real surgery will not be there, but I'm really impressed by these Bionico eyes. They're absolutely incredible. They're very similar. And the most important things here are positioning, head positioning, scope positioning, hand positioning, and then the specific steps for each of the devices. And you'll get a really good view. We have the Ingenuity 3D visualization system here, which is phenomenal as well. So anyway, we hope you enjoy. Kick back. Let's try and have some fun, learn a lot.
And also ask all the questions. Come on, guys.
Ask
in the chat,
yeah.
Ask questions so it can be interactive, okay?
All right.
So let's start.
Okay.
I'm really looking forward also to see all the ergonomic tips, and we're gonna have multiple cameras in order to just catch everything you guys are doing.
Actually, maybe what we can do is how can use me as a model and teach me, if like it's the first time I'm using MIGS, how to position the scope, the patient, and myself.
Okay, perfect.
Yep.
Okay, so you're gonna sit facing that way, and the scope is this. No, just kidding. Okay, so. First time surgery. This might be better from a side view if we can move the camera a little bit, otherwise it's okay. So there's two key aspects of positioning the patient for MIGS surgery. The first step is when you'll be creating your incisions, implanting or inserting your OVD into the eye. And then the second position is when you're actually implanting the device and you're aiming to get a view of the angle with a direct prism style lens, like a Swan-Jacobs lens. So initially the patient's head will be face up with the patient lying face up. And for this, it's basically the same ergonomics positioning as your regular cataract surgery. However, in order to get good visualization of the angle with the Swan-Jacobs lens, you're going to have to tilt the patient's head about 45 degrees away from you. So I like to think about pushing the nose away from me as a surgeon, so you can do that, Jose.
Yep.
And what I like to do is I get the eye in my cataract view, so you can see it there on the main screen. So that is your cataract view, right? Then you tilt the head about 45 degrees away from you, okay? And then I like to think about tilting the scope just enough so that you can see the eye again. Okay, so Jose is going to start tilting, and then you'll see the cornea, and there's your view. And that's how you know that you're there, okay? And that's usually enough. The idea is to have a head-on view of the angle. What do we mean by head-on? Think about looking at a building from the sky. If you're looking at a building from the sky, from an airplane, straight from the top, you can't see the windows. You're looking at the building like this. But if you tilt your view, can you see my hand here? There. So imagine this is a building from the sky. This is the X where the helicopter would land. You're not able to see the windows or the floors of the building. And as you tilt your view, you'd be able to see all of the different floors in the building. And it's the same for angle surgery. If this is the iris and you're looking right top to bottom, corneal apex to visual axis, you won't see the different elements of the trabecular meshwork. But if you tilt the patient's head and tilt your scope towards you, you'll now be able to see all of the angle elements, right? So you'll have your ciliary body band, your scleral spur, your trabecular meshwork, and your Schwalbe's line now from a direct head-on view. So that's what you're trying to achieve here, okay?
Yeah, okay, got it.
Perfect. So Swan-Jacobs.
Swan-Jacobs.
Really, really light touch on the cornea.
Yeah, this is very important.
This is where the model differs from real life. This model is very lenient, very forgiving, in that you can press as hard as you want, and that this cornea will get no folds. By the way, this eye doesn't have OVD in it yet, so
I have to put it.
We'll go back to that in just a second. So very, very gentle touch, okay? And you're going to basically
I have it there.
Tilt the Swan-Jacobs towards you to get a good view of the angle. And you can see the angle there. That's step 2. So that's a really good view. Light touch. You can use your pinky and your ring finger to, like Jose is doing here very nicely. His pinky finger and his ring finger are supporting on the patient's cheekbone.
Yep.
In this case, if it's the right eye, then it would be the forehead. And this allows you to float the Swan-Jacobs lens. So these fingers are really light of touch, and they're floating above the cornea, whereas these fingers are supporting all of the weight of Jose's hand and his arm. Okay. Yeah.
That would avoid for you to give an extra pressure to the cornea and have some distortion of the image.
We can kind of see the angle there. We will see it better once we implant the OVD, and Jose will go over all of this again when he does his eye stent. And just show us the angle there for a second. And the third important thing is magnification. So view is everything, and good magnification is part of a good view. And there he is, nicely magnified, nicely centered, and that will allow you to quickly discern all the little differences in the structures of the angle to make sure that you can implant the device exactly where you want it, exactly where it needs to be.
Yeah.
Okay?
There we go.
Perfect.
Get some OVD inside the eye. So you already made an incision?
Yeah, let's give you main incision. Okay, so for your main incision, you would have your patient in your regular cataract position. Side port. Do you want to just do a...
I don't know, maybe a 2.2?
Yeah, just do your main.
It's 2.8 actually, but it's fine. So here, considering we're doing a cataract surgery combined with the eye stent, so the patient is going to be in the regular face-up position. Okay. Here we go.
Okay, so Jose is going to start with an eye stent inject. You'll see there's an eye stent inject and an eye stent inject W. The eye stent inject W is a new generation. It's wider. It has a wider flange, and it was designed to prevent the overly deep implantation of the device. So you're going to make your main incision, OVD inside your eye, just like your regular cataract surgery. Tilt the head 45 degrees away from you. Tilt the microscope towards you until the eye is in view.
Yeah, you got it right there. So yeah, so the important thing is to use a good amount of OVD on your cornea, so you can have a better image, clearer image, and support for your Swan-Jacobs. And before I recommend, before even starting the surgery at all, it's a good idea to practice the use of your Swan-Jacobs, and also try to get in focus and with correct or right alineation of you and the head of the patient, and make sure you have a good visualization of the angle. Here I have a central view of the angle. I have some air bubbles inside my AC, so this is going to be difficult for me to move my hand inside my eye. So it's a good idea to get this before even getting your device of the package. There you go. So
okay, that's a much better view.
That's much better view.
So that's a key point. And you know, this is relatable to real life because if you don't have enough OBD inside the anterior chamber, you're going to create a lot more folds with your Swan-Jacobs lens because the pressure inside the AC is very low. So even the slightest little pressure of your lens will create decimates folds on your cornea and then preclude your view. Okay, so that's really nice view. So now let's just show the injector here. Before you even
where's the camera? Right here. So here's the injector. It has a protective sleeve. You before inserting, you have to take it out, obviously. Here you have the injector. This
slider.
Yeah, the slider will retract the sleeve, so the trocar will be exposed, and then you can proceed to inject the device. So first of all, you have to take the sleeve, and a good way of holding it is using the knuckle of your middle finger towards the injector, your thumb, and have some pressure within both of them. So this gives you stability, and it's easier once you're inside your eye to keep a better central position of the injector and the device. So your index finger needs to be free because it would retract the sleeve like this in order to expose the trocar and inject the device. And also when you get your device off your eye, helps you protect the trocar so you won't damage any structure inside your eye. So this is a way of holding it. And even I give you a couple more pearls once you're inside your eye. But remember to do a good pressure between your middle finger knuckle and your thumb. So you have to be you'll be more stable inside your eye, and it would be easier to inject.
So Jose here is just going to show how we're going to get a close-up of the button as such, just the slider. So if Ivo can just show the slider going back and forth.
Okay, there you go.
And now we're going to show. Now we're going to show under the actual operating microscope. So look at the microscope view and try to get that in focus so that people can see the sleeve. And this is a protective sleeve basically, so that the trocar doesn't get damaged when you're inserting it into the eye.
Oh,
we're having changing the illumination. We're going to blue light here. That's okay. Just focus on the sleeve and we'll do it for now.
So I can move. So here it is.
So there's retracting the sleeve. Focus a little bit better.
I can. It's
the other one's on top there.
No, it's off.
Okay.
Yeah, there you go.
So that's better focus.
So here's the sleeve on,
and then the sleeve is retracted there, and you can see there's a cannula and there's a trocar, and it's really important when you're implanting the stent, when you're clicking the button, it's really important to make sure that trocar is centered in the injector cannula. If the trocar is offset, meaning it's not centered inside the cannula, the implant can get stuck when being ejected out of the cannula. And I think that's the key point for especially the eye stent inject W, which is a little bit wider. It can get stuck a little bit easier if you're not centered.
Good. So
let's try to get that blue light corrected before we go on.
Actually, there's no light at all. No. It's not turning on. Creo que será esto. Aquí está ya. So it's always good to have, as Carlos said, good magnification, but also the maximum light. I like to use the maximum setting in light, so you have a better view of the angle and you're more comfortable with it. Maximum illumination, maximum.
So lots of OBD on the cornea. This is one of those situations where you don't want to get cheap on your OBD because it really makes a big difference in the view. If you have very little OBD on the cornea, you're going to end up causing decimate folds and hurt your view.
And also bubbles.
Yeah, air bubbles are always a thing here.
Are a nightmare all the time.
Yeah, air bubbles are not the MIGS surgeon's best friend. Look, you have a bubble
Yeah,
in your lens there.
in my lens.
I'm glad that happened because that does happen often. So
Yeah,
it's
a
good
lot.
to have a good scrub nurse that is clearing the bubbles and wiping your lenses for you.
So nurse,
Is that
please.
clean now? Sorry, I don't have the.
Can you wipe the sweat of my forehead?
I don't
too?
have the certification to do that, sir. I'm sorry.
So here we are, no bubbles. So magnification.
So he's zooming in and focusing in, and that's a much nicer view now. Great, even better zoom, excellent. So you can see your structures there, and this is what we meant about having a parallel to the iris plane view, a direct view of the angle, as if you were standing on the temporal iris looking out across the pupil. The iris was a carpet and you're looking at the corner of the room, and at the corner of the room is where your angle is, and that's where you can see your ciliary body band, your scleral spur. So there's the injector.
So there's the injector.
And it hasn't been retracted yet. So now as the slider button comes back, you can see the trocar now. And there's your trocar and your cannula, and they're exposed.
So once the trocar is exposed, you need to get close to your TM. Here it's really easy to see. So it's happening the same to me. The bottom, my finger is getting in the way.
Yeah, you might want to tilt the eye a little bit more towards you.
And that usually helps there, just like that. If you tilt it a little bit, so less of
tilting.
ideal
Then I just flatten my finger,
view. There you go.
and here we go. So the trocar, you can see it in the middle of the sleeve. So you have to approach your trocar to the trabecular meshwork, and there is something called the dimple technique. You want to develop more about it, Habo?
Yeah,
Oh,
you're
it's fine.
basically going to create a dimple in the trabecular meshwork.
you
So
go.
you're going to push the trocar into the TM, and then it's gonna create a little convexity. A concavity. Yes,
Concavity,
that's the word. A concavity, and that's what we call the dimple. And once
So
you create
you-
that dimple, you know you're applying the right amount of pressure. Make sure that trocar is centered, and
It's
then
centered. You don't want to do this.
yeah, exactly. That's great perler. That's the wrong way to do
It's
it.
the wrong way to do it.
Where your
Yeah.
trocar is engaged and you're shifting the trocar inside the cannula, and that's where the device gets stuck.
So once you get into a trabecular meshwork and have your trocar just right centered, you do dimple, and when you're
Dimple,
sure,
and then click the button.
and kind of, there you go.
So you're twisting there. Watch
Yeah,
your view.
twisting it, and have a really bad view. There you go.
I have noticed that your hands tend to get in the way with the
Yeah, a
simulation,
lot.
and
Tends
it's
to
not
get
as
in the
easy
way.
for this to happen in real surgery.
Yeah, it never happens actually. Yeah, so
Okay,
you have
there
it
you go. That's good. Centered, and then you click.
Center, press
sure-
your knuckle and your middle finger.
Make sure you're not twisting that cannula. Good view there.
And let me get a better view. There you go.
And now, okay, so
this
key thing there, make sure you pull back before you release that button. So you're going to click, then you're going to pull back, and then you're going to release that button. So you're going to click the button and keep it down.
you're gonna click it again.
Yeah, so click, pull back, and then release. See, that's the second click
There you
is
go.
the release.
Yeah.
First click is deployment. Second click is release of the mechanism. And this is important, even more so with iStent Inject W, where it tends to be more sensitive to this second click. So do not release the button until you've pulled back your cannula and you can see the implant. And that's a really nice implantation.
Yeah.
We see the iStent in the crossing through trabecular meshwork in Schlemm's canal. And of course, in a real eye, you would probably see a little bit of reflux, of blood reflux from Schlemm's canal and through the inlet of the implant. And now this has two stents.
Yeah, for the second stent, I don't know if you like to reposition your scope and your seat, or just move your injector
Yeah,
to the nasal plane.
Yeah. So that's completely surgeon preference. I try to implant them about 2 clock hours away from each other.
Yeah.
There's two ways to achieve this. One of them is to basically, so what you did here is you implanted it right in front
In
of where
front
the
of you,
cannula,
yeah.
exactly. So I tend to go a little bit to the right, implant one, and then a little bit to the left and implant
On
the
the
second.
second one.
But for practical purposes, we're just going to implant the second one a little bit to the left. As long as you're about 1 clock hour away, you're honestly fine. And what you do want to make sure you have is a bit of reflux. So pull back and then release. Beautiful. Great. Okay, so look at that. Great.
Happen.
That
yeah.
one's not exactly where it needs to be. It's not deep enough.
No.
And I'm actually glad this happened because it does happen sometimes. And this is how you solve this. You're going to recannulate that stent, get a little bit more zoom, get closer in there, zoom in a little bit more. And this is fun, actually. And all you got to do is make sure, and the stents float inside OVD, so it's almost like you're working in space. And you just have to recannulate that stent with the trocar, with the trocar. And if it starts going too close to the cornea, you can always use a little bit of OVD to bring it back down,
bring it
so
back
that
to
you
you,
don't
yeah.
harm the cornea there. Awesome. So focus in. You're almost there.
Nice.
And this will happen. I'm glad this happened because this will happen to you at some point
Yeah, it's
during
really
your
common.
MIGS career, and you got to know how to solve it. So you're gonna, so watch it there because you're recannulating it backwards, right? So you've got to flip it around.
Yeah, but
It might be easier just to use OVD here. I mean, now make sure you protect your trocar there. So slide forward again. Perfect. So now
before
your trocar is
extracting it,
protected.
yeah. Let me take some OVD.
And there you go. So a little bit of OVD, float that eye stent, flip it around, make sure you have a head-on view of the inlet, and then recannulate it with your trocar and go on for it. There was air in that
A
OVD.
lot of her. Yeah. Thanks so much.
Great scrub nurse there.
Yeah.
That's a great side view of the eye stent. I mean, this is the cool thing about the
This is really
about the
nice, actually,
simulations.
yeah.
I mean, you get to see all these things that are totally not stressful, and in a real life they could be, but this is how you solve these issues. So that's a really good intraocular view of a stent from the side. Focus in a little bit more, a little deeper. There you go.
It's perfect. It's better.
Excellent. Yeah, so just nudge it. There you go. Nudge it until you can see the inlet. Almost there. And now,
It's just floating around.
Yeah.
It's teasing me.
yeah, it is tricky. It is very tricky.
Really
and
tricky.
can get a little challenging, but it is doable. Just use a little more OVD to release it from whatever it's loading in.
So let me see if we can.
You can also use a micro grasper. If it's getting tricky, you can just grab it with a micro grasper.
Maybe I can with the.
Yeah, and just go ahead with the cannula. So your fingers are blocking the view there, just so you know.
It's a lot of blood.
There you
There you
go.
go.
Awesome. And there is a bit of capillarity happening there, or some kind of magnetism that's really
Yeah.
making your life a lot harder. I honestly don't think this happens as much in
No, in the eye.
I realize there
it's
might be some
easier.
kind of static from the plastic. I don't know. I have no idea, but it does seem like it's a lot harder
Yeah.
than it would be in real life. And that's good though. You're really showing like all the different ways to reposition it. And again, if you really are struggling, grab a pair of micro graspers, micro tires, or any other micro forceps, and pull the stent out of the eye, and you can do this outside. There's nothing wrong with that either.
Yeah, actually, it's easier.
Yeah, it would be easier. Do we have micro tires?
Yeah, I
here?
haven't.
Where?
Just remember to put the sleeve
MST
on.
micro tires. They're in your stuff.
They're around here. Where are the tires?
Ah, there you are.
Oh. So this is what I love about the simulations is everything is fun and everything is new. And then honestly, doing things like these is when we've come up with new techniques and new applications of pre-existing techniques, new maneuvers, because you're in a different mindset. Right now, the most important thing is to learn and not to ensure a specific patient outcome.
There's a question from the public.
Yeah.
Which conioscope do you prefer? And if you can give 3 options.
Well, I just use a Swan Jacobs, to be honest, and I use the re-sterilizable from Ocular Instruments. I have no conflict of interest. I just, that's the one my hospital has, and I do like it. The disposable one that Glaucos provides is also...
Is the one that we're using.
It's the one we're using right now. This is disposable in most countries, but I think in Latin America, you would be allowed to re-sterilize this one as well. The only thing that I find a little bit challenging about this particular one is that it has a lot of curvature, and it's got these two little wings that can get in the way for hydrus. And you'll probably see that when I implant the hydrus. So there it is. He pulled it out of the eye with a, I hope that answered the question about the gonial lens, by the way. So there it is. There's your stent, and it's outside the eye. And there you go. That's a lot easier to do. Just make sure it's all the way in. Okay, perfect. There you go. Now, yeah, make sure it's in and not, because if you don't put it all the way in, when you recover it with your sleeve, you can push it out.
Push it out. Yeah.
Yeah. I think that looks pretty good.
I think it's fine, right?
Yeah. So just check your sleeve before you go in the eye. Sleeve forward again. Yeah, that didn't fall out.
There we go.
Okay, you're golden. So there you go. 2 styles of eye stent repositioning in the, I'm not going to say likely, but you know, in the event that your implantation.
Yeah, this can happen.
Deployment. Yeah, it happens.
For sure. And
I don't want to say it's super common because it's a pretty good device, but it will happen. So now just remember, this device has 4 clicks, and the new generation will have infinite clicks. It's called the, in fact, the Infinite, iStent Infinite, but it's not available yet. So you have 1 click left. Your first one was a botch, your second one was successful implantation, and your third one was not deep enough, and that's why the stent came out of the Schlemm's canal.
Yeah.
So you have 1 click left, and that is a disadvantage of this particular injector.
You only have 4
which
clicks.
is why they solved it with the new generation. But Jose's a rock star here.
Remember to dimple.
Dimple, align trocar, good view.
I think I'm out of
I guess
clicks.
the best tip I can give you is don't click that button unless you have a good view and you're sure what you're doing. There's no such thing as luck in MIGS. You either see it or you don't.
I think I'm out of clicks.
Yeah, you're out of clicks?
Yeah,
okay.
I don't know why, but I have a,
I don't know. Did you try?
Yeah, I tried.
So where did the 4th one go?
I don't remember. Maybe give another click. So there we go. So that happened to me because I didn't, I wasn't dimpling enough, if that can be said. So you have to press enough to dimple and release your device. If not, that's going to happen.
Great. Okay.
So,
well,
okay, fine.
This is great. This is a full class because it's not like a look at how good I am.
Yeah, it's not like
this was
perfect,
and this is how it always goes. The truth is, these things do happen sometimes. Obviously, 1 stent is still going to have an effect on IOP lowering. 2 stents are clearly better. This issue, I think, will be solved with the Infinite device.
Yep.
I'm really excited to see that. And I mean, depending on where you are, you can always ask for another injector and go ahead.
Yeah.
Great.
Yeah.
Great. Also, props to Jose here. I have to say, I've done hundreds of these in real eyes, and the simulated eyes are actually a little bit harder, which is actually great because you're learning in a harder model.
And also the 3D.
Yeah, the 3D. Also, we're not used to doing it in 3D, but no, that was great.
That's good.
Good job. Good job. That was awesome.
That's good, man.
Okay, so now I will be doing a hydrus micro stent next.
Sure.
So we would have to use either a new eye or flip it around if that's okay, because that part of the TM has been used. Okay, great. So can you just set that up for me? Because I'm not sure about how that's.
So yeah, in summary, the pros for the iStent W, inject W, is position. Next, how to handle your injector. Use the knuckle of your middle finger against your thumb, and have your index finger free. So that will be more. You have more control. And you can have a more centered trocar.
Yeah. Let's show the iStent video because the plan was actually to show the video first and then the actual surgery to have something relatable.
Yeah, of course.
So if we can show podemos mostrar el iStent. So this is one of my videos. It is a 1-minute video. It's been condensed, so you won't have to see over there. So can I just
go ahead.
So there it is. That was fast. So you can see how I think this particular video is just one because I was trying to. Oh no, there it is. So look at the trocar there. It's centered inside the cannula. You can see the little dimple and then the click. Pull back, release, and there's the stent. And I do like to push on them sometimes. So look at this. When you have reflux there, that means you're right where you want to be. And here's another video where you can see a little bit better. So centered, click, okay? That one has reflux on the right and reflux on the left, and that's what I like to see. And this is the aqueous vein there. You can see how that aqueous vein blanches. Right in front of my cannula, there's a vein, episcleral vein, that goes white when you inject fluid into the eye. So that's the ice stent.
The ice stent inject.
So that's there you go, ice stent inject. Now we're going to show the hydrous video just so that you see the actual technique first, and then I'll do the simulation in order to talk about the actual pearls. So here we go, hydrous video, please. Great. So, oh, that was there you go. So, injector goes into your Schlemm's canal. Look at how I angulate the tip of the injector 45 degrees up towards the Schwalbe's line. That's really important because as soon as you start spinning that wheel and you start deploying the device, it tends to dip down or posteriorly towards the ciliary body. And then once that first window is out, you redirect the tip of the injector parallel to Schlemm's so you can continue deploying the device. You're going to see the 3 windows come out, and ultimately the jaws open and it releases. And this maneuver here is key. You want to parallel park, like you're parallel parking a car, pulling the device with a twist of the wrist in order to prevent pulling the device towards you. And again, we're seeing the aqueous veins here. And you can see the blanching of that little triangle in between the 2 main veins. You can see how the whole area becomes a little wider. And that indicates good flow. It's a little bit hard to see, but you will train your eyes eventually to see it. Okay, so let's do one in quote unquote real life now. So again, this is our cataract surgery positioning of our patient. My scope is it's straight. And I have a good view there. So for my hydrous microstent, I'll use a side port usually. And I do like to make 2 incisions. I usually make a side port to inject my OVD. So I usually do around surgeons 7 or 8 o'clock, first side port, which is my OVD side port. Do make them a little wider in these model eyes just because I don't want to struggle with my OVD. And ultimately, I'm not too worried about hypotony here, thank God. Let's have some Provis, thank you. So Provis to get a really good fill of the eye. And speaking specifically of the model eyes, make sure you almost overfill the eye so that you get a really good view. But when you're doing surgery in real life, you do not want to overfill because you will collapse Schlemm's canal, especially for eye stent, and you will make the implantation harder. But for these model eyes, just go to town, fill it really well, and that is your side port plus OVD. Now here is my hydrous incision, and before I actually make it, I'm going to grab the hydrous here, and I'm going to show you the device here quickly. It comes also in a cannula with a plastic cover for the sleeve. So is that what we're showing it? Okay. So, okay, just want to see a view of the camera there.
Here's the view.
Oh, there it is. Oh, yeah, it's really dark though. Okay, so maybe here.
There's this one's a better one. Yeah.
Here? Oh, there you go. Okay, there you go. Sorry about that. I'm new to these cameras here. So pull the protector out, and this is key here. 2 moving parts to this injector. I'm going to ask Ivo. I'm just going to try and keep it here and then ask you guys to center that camera so that you can see it properly. The first moving part is this rotating head, which will basically change the position of this angulation of your cannula. Okay, see how it spins? And you can see how that changes. Now, the second moving part is the spinning wheel, and this wheel deploys the implant. Okay, so the ideal position for me for this head is about 15 to 25 degrees pointing up, because if you remember the video, when I first engaged the tip of the injector into Schlemm's canal, I want to have a slight upward angulation of the tip, meaning towards Schwalbe's line. And in order to achieve that more naturally, I give that head a little bit of a rotation upwards, just like that. Second thing I do, so you can see it now on the main operating screen. This would be pointing down, and this would be pointing up. So I'm gonna angulate it just a little bit up, okay? Now, watch closely here. I'm going to spin the wheel, and when I spin the wheel, you'll see the device deploy. So spinning forward, 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 and there it is. And I always do this before I go in the eye. First of all, to make sure there's a hydrus in there. I've never not had one in, but you know, you never know. And second, to make sure that it's actually moving correctly and it's engaged in the mechanism that deploys it. So I deploy it a little bit, see the first window there, and then pull it back in so that it's barely visible there. Excellent. So now I'm going to put that to the side. Oh, before I do that, the hydrus incision is key. We call this a hydrus incision because it's not your typical paracentesis. So if you look at where I'm planning on implanting my hydrus, which is around here, so the device covers about 3 clock hours, which would be from here to there. So the curvature of my injector matches the curvature of the limbus at around there, which means that I'm going to make my incision, I'm going to use the second hand here. If my injector needs to enter around there, right, to have that curvature match, this is where I'm going to start my incision, okay? Now, very important, this incision is not going to point towards the pupil like your regular paracentesis. It's going to point towards the area of the trabecular mesh that you're going to engage, right? So this is a pointing towards the pupil, and this is a tangential incision. So it will be something like this.
It's a typical think outside the box situation,
yeah, a little
right?
bit of a think outside the box. Exactly. This would be towards the pupil. Yeah. You don't want that because you're not going to point your injector this way. I do like to make my incision a little bit wider, even in real life. And for the simulated eyes, it's really nice to just have a lot of space there. So there we go. Now we're going to tilt the patient's head about 45 degrees away from the surgeon. There you go. And now I'm going to tilt the scope until I have the eye in view again. And I like to have the apex of the cornea right in the center.
That's really nice.
So that's how you know you're in the right angulation. So OVD for the cornea, and this is key here. And I'm going to focus on the hand view here for a second. Let's try to look at my wrist here if possible. Is that a little dark? Or yeah, that's much better. Thank you. So this is how you hold the implant, okay? And you're going to go down into the eye like this. But this motion here, which is basically ulnar flexion, is really important. So this is how you get the implant into the eye. And this is how you do that parallel parking motion that I was talking about. Once the implant is deployed and inside Schlemm's canal, you have to remove the injector from Schlemm's canal. And if you just pull towards you, you're going to rip everything out. So this motion here will allow you to do this parallel parking in reverse out of the Schlemm's canal. So let's take a look now. So another pearl, I do like to insert my injector before I put OVD on the cornea. So I usually have my scrub nurse have the Swan-Jacobs lens ready. Scrub nurse.
Yeah, I'm here.
Thank you. So I usually do this, and look at how the tip of my hydrus is pointing down. Yep. So you can either point it down, which makes it a little bit easier to insert it, or you can also do that opposite wrist flexion to make it go in there. Either way works. So now I'm inside the eye. Why did I do this before putting OVD on the cornea? Because if I did this, then I don't know where my incision is anymore. And I'm going to be struggling to find that spot. So that's just a little pearl that I've kind of developed for my own peace of mind. And again, remember, lots of OVD on that cornea, center your view. You're going to very gently grab that Swan-Jacobs and just lightly.
Something cool to point out. Look how Havels positioning his hand differently than I did. He's supporting his hand over the patient's nose.
Yeah, you basically have to find, depending on the patient's anatomy, and your own hand anatomy and size and particular positioning, you've got to do it in such a way that you're stable, right?
Yeah.
So I have a pretty good view there. I'm going to zoom in as much as I can without losing quality of image, because you'll also notice that if you zoom in way too much, then as a principle of optics, you will lose a little bit of resolution there. So there it is, Schlemm's canal, my injector. I'm going to pierce through my TM. Yeah, the fingers do get in the way a little bit.
Yeah, it's getting too much.
In the way there. So I'm in, okay?
There you are.
And I'm going to focus a little bit better there. It does take a bit of a wiggle sometimes in real life, like a wiggle, wiggle, wiggle. And now look, the tip of my injector is pointing a little bit up towards Schwalbe, sorry. And then deploy. As soon as I see that first window come out, I'm going to release change that angulation and release the pressure that I was exerting towards the posterior wall, and spin the dial. Slowly watch. Taking my time. This is one step where you do not have to hurry. You take your time, make sure the stent is where you want it, and you'll see the small jaws slowly open. And this is the parallel parking in reverse. Motion of the wrist. Sorry, I'm a little bit off center here. I'm going to recenter there. Perfect. And parallel park. There you go. So now you can see you have the inlet and the transition zone. And I usually try to get a coverage of about up to halfway down the transition zone with TM. So a good way to reposition this is you can use a Sinskey hook or even just a vertical chopper. And so what do we have here? We got a vertical.
I think it's vertical and a
chopper.
swivel, I think.
I usually just use a Sinskey hook here, but this will do.
You have the micro rasper if you want.
No, that's fine.
It's fine.
Just going to show a little pearl here. I would probably just leave this here in real life.
Yeah.
It is a little deep. So look, with a Sinskey hook or you can engage between the inlet and the transition zone, and you're pulling it out. See that? That's a little better. Now that's a little too far out. So this is where the transition zone begins, and that's where TM is covering it right now. And this is the inlet right here. So now I'm going to push it in. So again, same thing. Go into that. Just there you go. So that's exactly half. And now you can see the 3 windows here, and they are in Schlemm's canal. Of course, the model is not anatomically perfect. No model is. So this device does seem to have migrated a little bit superiorly towards what would likely be your Schwalbe's, but this is still within Schlemm's canal. And a good way to know is that it didn't dip down. It doesn't have any bends. And the way the transition zone and the inlet are looking at you is straight up. If this little notch in the device is pointing down, and I'm probably going to explain this better with my hand here. If you're looking at this little notch head on like this, you're in the right spot. If it looks like it's tilted down towards the iris or tilted up towards the cornea, then you're probably not in the right spot. Okay, so there's a hydrus.
There you go.
Perfect.
Pretty good, man. Good job.
Great, thanks. These eyes are great. Okay, so let's go to a Kahoot dual blade now. Can I just flip this guy over here? Oh, ya tiene una stent ahí. No, that's the new one, right? Creo que sí. Great, so same principles basically. Kahoot dual blade. This is not a stent. This is a goniotomy. Goniotomy with trabecular meshwork removal. So some people do call it a goniectomy. The main difference between this device, GAT, and Omni and all the other
Trabectome.
Yeah, trabectome and all the other trabecular meshwork excisional procedures is that it has a dual blade which cuts both the anterior and posterior insertions of the trabecular meshwork, and you actually remove the TM out of the eye, and that's what's nice about this device here. So this is it. This is the this is what it looks like. That is the business end of your KDB, and you can see how it looks almost like a snowplow.
You wanna play the Kahoot video first?
Sorry?
The Kahoot video.
Let's show. Yep. Well, tell you what. Let me show the device first quickly. Because those videos are very short to save some time. So that's the device, and you can see how it looks a little bit like a rake or snowplow, and it has 2 cutting edges, one superiorly and one inferiorly, and those edges are going to cut your trabecular meshwork. And it's a pretty nice handle here. It's very thin. It's almost like a pencil, and it does have a nice aspect to it. These flat areas on the handle. See how it's round here and flat here where the name is? This tells you that you're holding it in the right position. So if your fingers are touching the flat spot, you have the KDB pointing left and right, not up and down. So that's something that I find nice. Okay, let's show the KDB video. So it's pretty simple. You basically just similar to the hydrus, you get a good visualization, and you are going to rake off the TM. Do we have the video? Cool. There you go. So insert it and then start advancing. You will see blood here, and you can see how the TM is being removed here as the KDB is advancing. And I do like to do a reverse movement. So you'll see how I flip the KDB over here. And what I'm doing there is cutting it on the other end, because this will strip it, but it will remain attached. So by doing a reverse cut there, I'm removing the left side of the Schlemms, and you can see a bit of heme, which is always good here. And with a pair of micrograspers, I'm actually removing the trabecular mesh there. And you can see there in a gonioscopic view on the left, so look at the bottom right corner, and you can see the fresh TM. And here I'm actually using the single mirror, and this is a mirror view, and I'm using the KDB to extend that goniotomy a little bit more. So yeah, I guess we can do that too here today. I'll explain that a little bit better. The video is a little too short. So same principle, OVD in the anterior chamber. Now I'm going to use so for this one, you're obviously using your main incision for your phaco, and this is a temporal incision. Pretty much your standard phaco incision here. This is a 0.4, I believe. And there you go. I just went right through the eye. Yeah, you will find resistance of the cornea in artificial eyes is a lot more than your normal cornea, but that's also good because it makes it more gentle. So tilting the head 45 degrees away, tilting the scope. So this scope was already tilted, so I can already see the cornea there. And again, same thing, lots of OVD on my cornea. Try and get some nice coupling there.
More OVD.
I might need another viscode here. Yeah.
There you go.
Thank you. So viscode. Nice little buffer there. Same thing, I do like to go in with my device before. There I am. See, so I know that I'm in, I'm not struggling. Then I put my lens on. And we have a nice big bubble there. So we'll have to address that right now. Okay, so more OVD, please. So this is how you get rid of a bubble. I already have it, sorry. So with your lens visualizing, you can just inject a little bit more here. Get it out. You will find that simulated eyes have a tendency to let air into them if you gape your wound, which is going to make you really good at not gaping wounds, which I clearly failed at here. So do we have a cannula that I can just aspirate this with?
Yeah, there you go.
Actually, I'll just use this, I think. Let's see.
I think it's better
No, that didn't work.
To you.
Okay. There you go. Okay, back on track.
You need some OVD?
Yeah, a little more
small bubble
visco
inside.
here. Yeah, let's get it out again. Always a little tricky to use a scope that's not your own OR, but it's I think it's a good habit.
Have you ever done MIGS using Ingenuity?
I have, but not KDB or hydrus. I did a few eye stents, and I have to say it's great. I mean,
yeah, it's really comfortable.
You know, after a few minutes of adaptation, you're not even thinking about the fact that you're not looking down a microscope. It's actually pretty great. Okay, so same thing, coupling here. KDB. And here's the thing with these simulated eyes, and you need to get this angulation right. And sometimes you do need to have a bit more of a top to bottom view, which I know we've discussed is not ideal, but sometimes your hand will get in the way. So see, like if I do a proper head-on view, my finger gets in the way here.
Yeah.
So I'm just gonna pull it back a little bit. And again, these are just little differences and nuances.
I also think the height of the operating table is too low.
Right. Yeah. I mean, this isn't a real operating table. I think it's a good height. I think it's just, again, you're getting used to differences, right? Yeah. But this is good. It makes you a better surgeon. And to be honest, I do think I have the ideal setup where everything in my OR is perfect. And it's nice to travel and do different setups. I'm not saying this is not perfect. It's just different. So look, I'm engaging the tip of the KDB there, right? In the TM. Let me focus a little bit better there. Is that a good view for you guys?
Yeah, it's better.
Okay, and the angulation is important because if you hit it with the heel, you're not going to get in. So you need to hit it with the tip. And that's where I like to try and go as far to the right as I can and start moving until there it is. See, I'm starting to strip there. And I start moving forward. Now remember, this is sharp. So I do like to, two things, press quite hard against the outer wall of Schlemm's canal to prevent me pulling the device back and coming out of Schlemm's. And I also like to angulate the tip of my KDB just a tiny little bit up toward Schwalbe's line. That way, if I do end up messing up and cutting too far, I will cut a little bit into the cornea, which will heal, and not into the ciliary body, which will bleed, and we don't like that much blood. Even though we do like blood in the angle as a glaucoma surgeon, we don't want
Too much
to be
blood.
coming from the ciliary body because it can be profuse. So there it is. I've stripped a little. I've advanced about 3 clock hours there, twisting the Schwann-Jacobs in between my index and thumb will allow me to see a little bit more real estate here. Keep advancing it, and then I will do that reverse. So I'm gonna pull back out, and then I'll do the reverse implant here. Focus a little better, and then exactly the same motion, but in reverse now. Trying to engage TM, there you go. And then you would actually, this is obviously not real TM,
Yeah.
so we won't be able to excise it, but I think you understand the, there it is.
Principle,
So,
yeah.
so there would be your free TM that you can now go in with a pair of micro graspers and pull it up, right? Now, if you don't have a Swan-Jacobs, or if you're trying to do a KDB of more than just say 4 clock hours, which is realistically what your Swan-Jacobs will allow you to do. Let's grab it. Superior aspect of the screen. You can see how I've damaged the TM on this little Bionico eye. So you can do the same to actually excise a little more, except it's a mirror view. It's a little trickier, can be done. And you can basically just do the same. So here's a key pearl for both Zen and KDB with this mirror. When you're finding yourself inside the eye, you're going to look through the central mirror because it's not a mirrored image and your movements are not inverted. So right now I'm looking through the top to find that area of the TM that I still want to go ahead and ablate. So I'm looking top left of the screen right now, top left. And once I know that I'm in the right spot, then I look at my mirror, which is giving me the angle view, right? So now I'm looking at the bottom right. And then I can keep on going. See? And I'm going and going. And you can go on as much as your incision allows you, and there will be a limit. But this is how you can achieve a little bit more goniotomy. All right? Okay.
It's good.
So that's KDB. Now we'll do a Zen gel stent. So I think we can just use the same eye. Okay, let's open that guy, please.
There you go.
Here. So this is the Zen gel stent. Allergan, now AbbVie, kindly donated this stent. AbbVie Canada. New World Medical kindly donated the Kahoot dual blades. Again, I have no conflict of interest. I am a consultant for Glaukos and AbbVie. But these were kind donations and there's no conflict of interest in this particular event. Okay, so here is your Zen injector. So, all right. Zen. Perfect. So,
So you want to see the video first?
yeah, let's look at the injector first briefly, so that we can
Okay.
discuss that and then the video.
Just move the camera.
So I don't have a view of what I'm seeing through that camera.
I'll keep it centered. Don't worry.
Okay. So is that a good view?
Yep.
Okay. So
Perfect.
this is your Zen injector. Okay. This is a protective cover. This is a sharp needle. Okay, 25 gauge needle. So don't touch the tip of that until you do have to take out the little protective nail. But once you've taken that out, don't touch that. It's very sharp. This is a protective lock because this is the slider. And if you slide this, the needle retrieves and the Zen gets deployed.
Show it in that camera.
Okay, better. Okay. Better here? Okay, so.
This camera, right here.
Okay.
I
just don't know what I'm looking at though.
The battery. No.
That's reversed. It's inverted. Okay. This is inverted. That's funny. Okay. Oh yeah, because the camera is pointing towards me. Okay. So there you go. That is the lock. Here's the lock, the yellow thingy. And you got to pull that out. Okay. So you pull it out. And this is the slider. And if I move the slider back and forth, then the device retracts the needle and deploys the device. And the needle does have a safety cover there. Is that in focus there? Okay. I'll just show it in the microscope. I think it's going to be a little bit easier in the operating microscope. Okay, let's just put this guy back on there for me while I get that sorted out. Awesome.
To change the eye?
No, just sort of. That's good.
There you go.
Thank you. Perfect. Okay, so what are we going to do now? Where did that mirror go? There it is. Okay, let's show the Zen video. This video is just a little bit longer. So I've created a paracentesis there and a main incision. I personally like to create a very small subconjunctival OVD bleb to make space between the conjunctiva and tenons so that I can have room to move my needle and implant the Zen in the right space. So that is OVD. OVD provisc bubble, subconjunctivally, supratenons. There's a tip of the injector. When I move the slider forward, you can see the Zen device coming out. That's a collagen, porcine collagen, recombinant cross-linked collagen. And I push it back into the needle, go into the eye before I put the OVD on. That's just a preference. Some people don't do that. Couple my lens, and now I'm looking through the center first until I reach the angle, and then I'm looking at the mirror. So see how I move my scope, and I'm going to try and focus that needle in the center of my mirror. So you're looking at the right-hand side of the lens there. You can see how the needle is right at Schwalbe's line there. Insert the needle, and then I will retrieve the mirror and use either a Vera hook, which is ideal, but in this case we didn't have one, so I just used a pair of forceps to infraduct the eye. I will continue advancing the needle in the same angle until I see the tip of the needle in the area where I want to implant it. This is now subconjunctival supratenons. A slight rotation of the injector so that the bevel of the needle is pointing towards 12 o'clock in the eye, zooming in, and then pushing the injector forward. First, the device is deployed, and second, the needle is automatically retracted as the slider keeps going forward. This step is key. Make sure you keep pressing against the angle and try to avoid flicking. And that means lateral motion of your hand. So I do make sure that there is no pressure, and see how I remove the injector by just pulling back and not side to side. Hard to see in the screen, but there it is, Zen gel stent inside the AC, about 1.5 millimeters in at about the level of Schwalbe's. And this is what I've always also been doing in all of my Zens, is an intraoperative needling. So sometimes as the device is deployed, it gets caught up in a few of tenon strands, collagen strands. And you can see how it's bending there. And I'm actually not touching the device. I'm needling around it. And it tends to bend because it was stuck in tenons. And now it's free. And I also have my mitomycin C already prepared in this same syringe. This is 0.1 cc of 0.4 milligrams per milliliter mitomycin C. And this will prevent excessive fibrosis and will ensure a nice bleb. So now we have a nice filtering bleb there. You can see the device subconjunctivally. And we obviously remove the OVD from the eye, fill it with BSS, and make sure that there's a nice filtering bleb. But you can already see it there. So there we go. We aspirate OVD, and you'll shortly see how there's a bleb quickly forming in the supranasal quadrant of the eye. Of course, wound hydration is really important. Make sure there's no leak, because you are at risk of light, probably numeric hypotony. So I do like to put a stitch in there in case the patient rubs their eye, or in case you need to do digital ocular compression post-operatively to increase the flow of the device. So there you go. That was a little bit of a longer video. Now we're going to do the implantation. Of course, this eye has no conjunctiva, so you won't see a bleb, but we will be discussing the critical steps for successful implantation. So the view will not be tilted in this case. This is your traditional phaco position of your microscope. So I'll be recentering it here. And for your Zen, you usually use a 2.2 millimeter blade. Two things here. One is if you've already done a cataract or you're doing a simultaneous cataract and Zen, tell you what, I'm just going to flip this guy over because it's going to be easier to show a right eye just for the video purposes. So we'll make it a right eye here. There you go. Perfect. So we have a right eye. I wish it was this easy to switch patients around in real life. Left eye, right eye. Simultaneous.
That would be awesome.
Yeah. Okay, so two things. If you've already done a cataract in the same procedure, then your incision will be around here. So this does limit the quadrant where you're going to implant it to where your incision allows you to move your injector, right? But if you're doing let's say like a solo Zen, either in a pseudophakic or a phakic patient, then you may want to move your incision a little bit more inferiorly in this case, so that you get a little bit of a better access to the quadrant that you want to implant it in. Ideally, you want to be in the superior most area of the supranasal quadrant. So this would be the inferior border of the supranasal quadrant. This would be the superior border of the supranasal quadrant. You want to go as superior as you possibly can. Okay, so let's create an incision here. In this case, I'm going to make my life a little easier. I'm going to go just slightly inferior now. You don't want to go too inferior because then the cheekbone is going to get in the way. Yeah. And then you won't be able to have the right angulation of that needle to exit at about 2 millimeters from the limbus for your Zen, okay? Yeah. So either temporal or slightly, if it's a right eye, slightly inferior. If it's a left eye, slightly superior. Work on my focus here. Sorry, let's just reset the scope.
Yeah.
So key thing here, don't ever be afraid of resetting your scope halfway through surgery. It actually will make your life a lot easier. If you've run out of XY or you're too zoomed in or too zoomed out, there is absolutely nothing stopping you from recentering, repositioning, moving your stool around, and make sure you're comfortable, nicely focused. This is your patient, and you want to do everything you can to ensure success. Want me to pause?
You're good?
Okay, good. So slightly inferior, and here we go. 2 millimeter incision. Okay. Perfect. So pointing slightly towards a supranasal angle, I'm going to go a little too deeper just to show you. This is the area where I'm planning to implant this device. Okay. So now I'm going to need some kind of a Weck spear or a little Q-tip or just anything to maybe even these forceps here. So make sure that your Zen device, sorry, your Zen implant is not stuck in the mechanism. It does happen sometimes. So let me focus here a little bit. So look, when I move the slider forward, is this in the way? I can take my hand off there. Is that better? Okay. Okay. So when I move the slider forward, I'm just gonna rest it on the eye here. You normally don't do this in real life, but I can because it's a model, so I can do what I want. There you go. So here comes the Zen, right? Now look, I've moved the slider forward, but if I retract the slider back and the device comes back with it, that's not good. that means that when I implant it in the eye, it's going to pull back out of the eye or back into the anterior chamber, I should say. This is good though. It came out, and when I retracted the slider, it did not pull back. So we're good. So now I'm just going to use either the back of an instrument or a wax spear or anything blunt to push that Zen.
back.
And you can also just flick it here and give the needle a little flick. Please stop moving your head, sir, ma'am. Look at the light. Classic. Okay. There. So now I'm just going to show the needle again here. Bevel up. So the device is out
This
there.
is out, yeah.
Device is out there, so I need to put it back in. So yeah, I do like a wax spear. It's the easiest thing to do. Probably should have brought one, but anyway, good focus is key. And then you're just going to push it in like that. See, there you go. Just gently nudge it so that it's inside the needle. There you go. And there. So the device is now there. And there you go. It's gone. Okay, disappeared. So we're good. Now, can I have the mirror here? I do like to put a little bit of OVD on my gonio mirror here. Do we have a little more here? I got one. So I'm going to get rid of the old
This is a new one,
So
right there.
awesome. Man, this is really, really good service, Evo.
Told you guys we're going to need a lot of OVD.
I was promised champagne though. Where is it? This is Claude. Can you change the camera?
The money for the champagne went to the OVD, so
Here, I'll just
forget about it.
Okay. Cool. So bit of OVD in my mirror. There you go. See it there. And
You have in the AC OVD already?
yeah, this is the same eye that we use for the KDB.
Oh,
so
good,
the TM won't be a little damaged, but that's okay. And so this is key here. Look, when I am inserting the needle into the AC, I want to do the little wiggle because, and this is key whenever you're inserting anything sharp into the AC. This wiggle here will allow you to use your incision without creating a new one because this is a very sharp needle, right? So if I just go ahead and pierce like this, I'm going to go right through. See, that's just the needle. That's not my incision. So wiggle, make sure you kind of hard to find it here. So I'm going to go in with my forceps and try and locate my incision first. We went a little, there it is. We went a little inferior. And this is what I meant about being careful with the air. So there's my incision there. Okay. So a little bit of a shuffle, wiggle thingy. There you go. So I'm through my incision. Perfect. So now look at how I'm holding. And this is a little hard because this model tilts. Can you just hold the head for me for a second so that it doesn't tilt on me? There you go. Perfect. So
Actually, you can zoom out a little bit so we can see the Hab's hand position.
me or Evo?
Evo.
Okay, good. So again, OVD on the cornea. So see where I'm grabbing the injector here? It's got this little notch here so that your fingers go in there, okay? And this is the slider. And I'm not going to touch the slider. I like to keep my finger here or here to prevent myself from moving the slider inadvertently while I'm figuring out what I'm going to do inside the eye. So a finger goes either here or there. It depends on your hand size, the patient, how, where you have your other hands located and all of that. So OVD on the cornea and the mirror. So same principle. Okay, so first thing, this is a good pearl for your mirror. You only have one mirror here. So you want to point it exactly opposite to the quadrant that you want to implant it in. So so right here, the mirror is in the infratemporal quadrant of the eye, which means that it will be showing me the supranasal image. If I do this here, I'll be seeing the nasal TM, correct?
Correct.
So I'm going to put it infratemporal, the mirror, so that the view that I'm getting is of the supranasal quadrant. And there I am. Okay.
Okay.
Perfect. So to locate your needle in terms of your clock hours, so like 12 to, sorry, somebody just hit the back of my chair. Please kick that nurse out of the OR forever. Just kidding. Okay, so this is your 12 o'clock. This is your 3 o'clock, right? And you're moving it, looking at the center non-mirror lens. And once you're ready to choose your posterior to anterior location, meaning your ciliary body to TM to Schwalbe's line location, then you're going to look at the mirror. So I like to get my needle in really close and make sure that I'm in the quadrant, so supranasal or superior part of the supranasal. Then I look at my mirror there, zoom in, pierce through my Schwalbe's line, and then I remove the mirror, okay? Now, with a pair of forceps or a Vero hook, you want to create a little bit of counter traction here. And we usually use an incision here, which, there, so,
yeah.
and now you basically want to keep pushing until the needle, sorry, that came out not great. Can you hold the head, please? Thank you. So you basically want to make sure the needle comes out about, there you go, 3 millimeters from the limbus. See, so now the needle is out there. Zoom in, okay, zoom in, focus, and then you rotate the injector between your fingers. Okay, so now the bevel of the needle is pointing towards the eyes 12 o'clock. And now you slide the injector forward. You slide the injector forward, and you can see the device is being deployed. And if I keep sliding, look at how the needle retracts. So I'm only sliding forward, and this is a great little injector where it has a dual action. So the first part deploys the device, and the second retrieves the needle. Now, this is key here. Before you finish pushing the injector in, make sure that you're having positive pressure against the angle, pushing forward, so that when the needle disengages and goes back into the cannula, you don't flick it. And I'll talk about flicking in just a second, but so when I remove the cannula from the angle, I'm pulling gently, gently parallel to the axis of the cannula. So very gently. I flicked it, so I screwed that one up.
Yeah.
But so the idea is to not flick it. I didn't pull it out, fortunately, but I got a little stuck there in the plastic of the simuli, but sorry, the simulated bionicle eye. But so see, this is pulling back correctly. What I did there, I flicked sideways like this. Okay, so that's what you want to try to avoid. This is a nice implantation though, and I do like to check again.
So as you pull gently,
yeah,
you push with your other hand, with the forceps you have, towards the incision site.
So that's a good question. So once the device is deployed and I'm trying to retract the cannula out of the eye,
yeah,
I release all tension, including the accessory hand. Okay. And now I do like to always verify that the implant is in the correct position with my mirror. And this will be a little bit tricky to see perhaps, but we can try. So again, let's try to focus in here.
There you go.
There you go. It's
there it is, right? Is that it?
Oh, there it is. Yeah,
near the bubbles.
There it is. Yeah, it's a little deep there. Here, let's. So there it is. Nice. That's actually good. It's hard to see, but
give me more light.
Now I'll give you another trick. If you can't see it here because there's a little bit of blood, or you can't see it, you can always use a cannula. And this is a pretty cool little maneuver here. Just a second here. So you can use your OVD cannula right where you think your implant is. And if you go like that, you can see it above the cannula. See that? So it's a little hard to see, but I'm flicking the inner portion of the Zen. I think that's pretty good focus, all right?
Pretty good.
So as I pass the cannula under the Zen, you can see the color difference, right? You can see that yellowish hue, and that's a really nice, it's a really nice placement. You have about 1 to 2 millimeters of intracameral portion and intrascleral portion right here, and then you have your what would be your subconjunctival, right? So
right.
So this would be your bleb here, and then you would do your knee.
So nice. So we did bleb. Good.
So that is a Zen.
Amazing, man. Okay. Excellent, man.
So how are we doing on time?
You do the pressure flow?
Yeah, so I think in the interest of time, we were going to do pressure flow, but in the interest of time, we're gonna stop here. We will do it, so I'll be back, and I'll get some pressure flow eyes that have a little bit of a softer sclera, which will allow us to show the entire technique. It can be a little bit tricky to do pressure flow in regular regular plastic eyes because the sclera doesn't, the tunnel doesn't stay open in the sclera. But anyway, I hope this was helpful. I had a lot of fun, so it was
Yeah, me
definitely
too.
worth my Friday night. I mean Monday night.
Monday night.
And
I think for you, every night's Friday. So
yeah, exactly. Do we have any questions from the audience?
all good.
Is anybody watching?
Everybody ready for the next time.
Awesome.
Yeah,
I'll
sure.
see you soon. Thanks.